Good afternoon, everyone. It's a pleasure being with you here. I hope everyone enjoyed the first day of ACAS, this beautiful hybrid model we have. It's my pleasure to moderate this good evening we have here with two of my very good colleagues. And we're going to have a nice discussion about acetabular reconstruction in complex and revision cases. So it's my pleasure to be working here tonight with Curtis Hartman, who's an associate professor from the University of Nebraska Medical Center, as well as David Watson, who is an assistant professor in orthopedics, University of South Florida in Tampa. We'll start with David's first presentation. David, you have the podium.
Thank you, and welcome to this afternoon's session on acetabular reconstruction. I'm going to start just by discussing the relationship between current indications for surgical intervention in the acetabular reconstruction world and matching that up with the implant offerings. The first thing I want to do is just take a moment to state what's probably the obvious to most of us, and that is that regardless of how you approach your acetabular reconstructions, depending on your training or preference, the overwhelming majority of acetabular reconstruction is going to be done with a hemispherical cup. And that's certainly true in my practice, which is a fairly diverse practice. I do a lot of trauma, post-traumatic reconstruction, as well as what you'd consider standard revision in the arthroplasty world. My practice is moving more and more towards hemispherical reconstruction, probably in excess of 95%, maybe even close to 98% of the time now, with the only notable exceptions being the metastatic disease or post-radiation bone, or that rare case where there's just so much bone loss that I'm thinking of using a custom triphalangeal. That's becoming rarer as our implants improve in the hemispherical shell world. I want to go through the common indications and look at the challenges that we face as reconstructive surgeons. And certainly, aseptic loosening has been the biggest indication for revision surgery over the years. And if you look at the radiograph on the left, you can see that the common radiograph of osteolysis from polyethylene wear. Certainly there can be fairly dramatic bone loss, but in this scenario, there's rarely significant soft tissue compromise, which is nice. And that's in distinct contrast to the x-ray you see on the right-hand side of this screen. That's a really unfortunate and relatively rare, I think, case where this 28-year-old female had this total hip done, her left total hip done 2 years ago, catastrophic polyethylene wear, and then the ceramic head simply eroded through the titanium shell. And you can see all the titanium debris. It's embedded in the bone, it's embedded in the soft tissue. It's quite toxic. This is all dead bone and fairly dramatic soft tissue compromise. Not nearly as common as the soft tissue compromise we see with the adverse local tissue reactions of the cobalt chromium ion disease that's more common. In this case, you see a picture of a trochanter that's bald, dead bone, and completely necrosed abductors no longer attached. And so you can see that it's really not just bone loss that we're being faced with, but also potential soft tissue compromise. And that is absolutely true regardless of the indications. Now, infection is becoming the leading cause of revision in my referral practice. And there's no doubt whether you're doing a single stage revision or two-stage revision, that by the time you've done an adequate debridement, there is going to be both bone loss and soft tissue compromise. Instability, I think, is a slightly different issue. And when we're talking about acetabular revisions, we're really specifically coning down on the malpositioned acetabular cup. that we think is etiologic in the instability. Most of the time, you're able to get a socket out, if it was a primary socket, without too much bone loss, although you certainly have to be prepared for acetabular defects. I worry a little bit more about the soft tissues. Depending on the surgical exposure the patient had, they might have abductor deficiencies. Probably if it was a posterior approach and recurrent instability, a soft tissue hinge posteriorly that's deficient, as in the case shown in the x-ray here, there could be trochanteric fractures. And so if we look at the common indications for revision surgery, there's two issues that we're faced with as the surgeon. And they're both issues that ideally we can get help with our acetabular revision lineup. We need to be able to manage various types of bone defect, and preferably we do it with ease. And also if there's something that the implant system can offer for improved postoperative stability to minimize that dislocation rate, that would be ideal. So I want to just talk about bone loss and what are the implications to the surgeon. I think there's two that are relatively inherent. Number one is, if you're planning to reconstruct with a hemispherical cup and there's significant bone loss, you've potentially dramatically diminished the amount of host bone available for ingrowth. And the second is that as you get decreasing available bone, you're getting diminished bone for that initial stability. Now, I don't know, and maybe some other folks could tell you how much host bone you need to actually achieve ingrowth. I don't know the answer. I suspect it's less than we think. But I can tell you, if you don't get initial stability, it doesn't matter how much bone you have, you will not get ingrowth in a good long-term outcome. Now, a second component of that stability is that as you're missing bone, we tend to move the cup hunting for bone in that initial stability. And that can put a cup position away from the ideal place. And it's this hunt for initial stability that's really been driving innovation in the revision lineup. If you look at this x-ray, this is a case where the patient had an acetabular fracture. It was treated non-operatively. They had a non-union, essentially a pelvic discontinuity, and the surgeon who treated it thought that it was a fairly stiff non-union. It happened years earlier, and they treated it with a primary hemispherical cup, and they hung it on a few screws. You can see that didn't work out well. And if I look over my career of just over 15 years of practicing in orthopedics, there's been significant improvements over a simple primary shell. I think the advent of porous trabecular metal has been a great improvement, both for initial stability, that friction fit, as well as reliable ingrowth. And then the addition of porous metal augments to aid in that initial stability, huge. And if you look at the way augments are used, they're placed usually superiorly, either superior medial, superior lateral, or posterior lateral, to resist the rate of biomechanical failure by falling into these holes. In a case like a discontinuity, those metal augments superiorly really won't minimize the medialization. And so the addition of a cup cage was a really huge advancement that changed the way my practice worked. And so that was my workhorse for this type of injury you see on the x-ray. If you look at the advancements that have been made, you say, well, are there future advancements that could once again change practice? And I think the answer is yes. If we look at what's intrinsic to a cup system that we need, well, obviously you need adequate sizing, because some defects like the one we see here are large, and you need the system to go to a reasonable size. Usually 80 millimeters is what most systems will go to. A high friction porous surface, I think that's the standard right now in a revision cup. Circumferential screw options, I think that's crucial. Most revision cups will have that. In most revisions where there's bone loss, I will use screws up the ischium, the pubis anteriorly, and then superiorly. So circumferential screws for stability. If you're tuning into this session, you're not familiar with Smith Nephew's revision cup, the locking screw option is perhaps something new to you. For me, it has changed the way I practice. I think it offers a huge advancement in initial cup stability, and you'll hear more about that later in the session. No cup can stand alone, no matter how good it is, and we need a supporting cast, and that's going to include metal augments to aid in that initial stability. That's for the initial bone stability, the bone defects. I think a system that also allows some agility in managing hip stability, so minimizing that post-operative instability or dislocation rate, is also huge, and that's something we're going to hear about further as well. I don't want to spend any time talking about the classification system of bone loss in the acetabulum. I think if you're interested or not familiar with it, I'd refer you to this classification. And I don't really want to spend any time looking at cases where, despite significant osteolysis and bone loss, a simple hemispherical cup without any augmentation can provide an adequate reconstruction. Certainly, I think there are advantages to some systems over others, but that really is not where I want to take us with in this exploration of implant choices in significant bone loss and revision surgery. It's really that hemispherical plus cup, the cup where you're going to use a hemisphere for your reconstruction, but you need more that's of interest. And there's three questions I always ask. It's, where is the bone deficient? Where am I going to put the hip center? And then how will I achieve a stable cup? And it's that question of how will I achieve a stable cup that's going to drive your implant selection. Let's look at this really relatively simple case from a reconstructive bone loss point of view initially. This is a 2B acetabulum, so superior lateral bone that's not there, and this 28-year-old lady with dysplastic hip. If we look at selecting a normal hip center, you can see that there would be a significant superior lateral defect, sizable enough that I would worry that mechanically my cup might fail early. Options, you could take a high hip center and medialize it. Not a great option from a biomechanical and wear point of view. You also tend to get a much smaller cup, so a smaller head, increased instability rates. Where I trained early in my career, this was treated with femoral head autograft, the number 7 graft, which is cumbersome. We also know that it doesn't incorporate it at as high a rate as we would like. And so with innovations in implants, we're now at a position where a normalized hip center and a metal augment superiorly is my reconstruction of choice. And you can see this clinical photo showing a cup. This is a redapt augment or small augment superiorly. And this is a case that we've got initial stability for our cup. It's at really minimal extra surgical time, increased stability significantly. This patient's allowed to weight bear immediately. If we look at a more involved case, this is the up and in type case, the 3A defect. This is a patient who had a total hip in excess of 20 years ago. She's been having pain for a long time. The initial construct, a little odd, that was a cemented porous cup, but she's had this catastrophic failure. If we look at the x-rays, she has intact columns. There is in fact an intact rim, just a large cavitary defect. So if we start asking, where's the bone missing? It's missing superior medial. We actually have an intact rim, so we could pick a normal hip center, but clearly, if you start thinking biomechanically, how would this construct fail? How might I not get enough stability for ingrowth? The answer is pretty obvious. It's that superior medial defect. If you look at it, we will be hanging a cup on a fairly sclerotic superior rim with no support up in this region. Clearly going to use screws in the ischium pubis and up the ilium, but still this is begging for an augment. You can see the reconstruction here. We've placed an augment in that defect, biomechanically improving the initial stability significantly. When that augment is unitized with cement to the cup or just with an intimate fit, it also extends the surface area for long-term ingrowth in the host bone. You can see that the screws that we've talked about circumferentially here, we have them in the ischium superiorly as well as in the pubis. And in a case like this, despite the significant bone loss, we were able to put the cup in a relatively normal position, normal hip center. I wasn't happy entirely with my anteversion when I was trialing it. So this system is agile enough to offer multiple liners. So we use a 20-degree face change, not just a hood, but a face changing liner. This patient has done very well. Let's look at one more case. It's a little bit more involved. It's a 41-year-old male who had an accident in Brazil, had an acetabular fracture treated surgically. That failed, and then he went on to have a hip replacement also in Brazil, and he presented to my clinic with this x-ray and two draining sinuses out of a laterally based skin incision. So obviously an infected arthroplasty treated with an implant. And a few things about this case. The first one, we opened him up and excised the draining sinus. There was really no abductors at all. The visualized muscle belly was just fibrotic and scarred. The draining sinus had come through the abductor tendons, and I debrided most of those, and there was just absolutely severe acetabular bone loss. I usually use a more functional type spacer, but this was a scenario where I said, I'm probably not coming back. It's such a bad problem. I'm going to put this non-articulating spacer in, get rid of the infection, and he's just going to have to live with his resection. Problem was he was 41 and kept coming back and kept coming back, and it looked like we were free of infection. So we said, all right, well, let's just see what your bone quality is. You can see these cuts of the CT scan. He has a non-union of the posterior column. He has very little anterior or posterior rim, essentially none. And he has just a tiny bit of anterior column that's intact. So it's almost a discontinuity with just a little rim of anterior column. Deficient posterior column, no real ischium down low, and certainly nothing to pinch up superiorly. So severe acetabular bone loss and abductor deficient. So if you think about a reconstruction here, you have some sizable issues. Number one is cup stability. And this is a case that I think is on the borderline. Can you get a hemispherical cup in here? I can tell you, this is one where I actually think maybe I should be going with a custom implant. If you say, well, let's try a hemispherical implant, which my practice has been moving towards, you look where the bone is missing, where am I going to put the hip center? Well, clearly I'm going to select a slightly high hip center here. There's no way to bring it down low. You'd have absolutely no support proximally. So we'll take a highish hip center. I know I'm going to have to medialize, so cotyloidoplasty, remount a little bit of bone, but with the thought maybe I get some superior support. I'm going to hang that cup circumferentially on screws. I know my cup's not going to be in an ideal position. It's not the cup, the position I'd normally put it in, 40 degrees of abduction, 45 degrees of abduction, and antevert, 10 to 15 degrees of anteversion, because I'm chasing bone for stability. I'm almost certainly going to have a column augment, a posterior column augment up superiorly to minimize that abduction force for early failure. That's the socket side. That's going to be challenging. And then if you think, well, hip stability, because just getting the metal parts in there is one thing. What about postoperative hip stability? He's abductor deficient. We're going to have a socket that's in a less than ideal position. I need some versatility here to minimize my dislocation rate. Historically, the answer for me would have been, well, let's consider a constrained liner. I'd hesitate to put that in a reconstruction that is really tenuous. I'd worry he'd lever out and pull my whole construct out. And at the age of 41, a constrained liner probably is going to mechanically fail sooner rather than later. You could say, well, let's just put a regular head in and let him dislocate. And once my construct has achieved bony ingrowth, then I'll go back and use constrain. Or something that we're moving more and more towards, particularly in these difficult scenarios, is a dual mobility construct. I'm also going to do some sort of soft tissue augmentation, like a glute max transfer, which is what I use for these abductor deficient patients. So here we are. This is the construct, and as sort of planned out, we have a high hip center. This is a all porous, non-modular revision cup. It's in a vertical position. It's relatively retroverted. Got circumferential screws. I have this flying posterior column augment that's cemented to unitize to resist that abduction force. And then we have a cemented dual mobility liner that's increased my anteversion and diminished my abduction angle. Also a glute max transfer. I think this patient is now almost a year out from this surgery. He's pain-free. He does have a little limp, but it normalizes with a cane. He's had no instability episodes. I think this is a great case to show that the advances in the systems we use really can have implications on the surgery we select for our patient and patient outcomes. All the cases I showed you have been with the REDAPT acetabular revision system, and it really is a full lineup now. Probably over the past 2 years, it's really reached its full potential, and my practice has evolved exclusively now for hemispherical reconstruction into the REDAPT system. With that, we'll finish, and you'll learn more about the REDAPT revision system. Thank you.
Thanks, Ran. So I've been asked to talk about acetabular revision and really to talk about the design features of the Redapt shell and why I think it makes it such a valuable tool in our armamentarium for complex acetabular revision. I'm going to touch a little bit on the background, and I'm going to spend most of my time talking about design features, and then we'll have a couple of case studies to hopefully bring home some of the points we addressed in the talk. So first, just as a little bit of background, we know that there are several requirements for cementless acetabular reconstruction. Number one, you have to have sufficient bone to provide that initial mechanical support for the cup. You have to be able to fix the cup rigidly to the bone for a sufficient amount of time that you achieve biologic fixation. And then lastly, that host bone has to be of sufficient quality and quantity so that that stable biologic fixation becomes durable over time. And without all three of those, cementless acetabular reconstruction is likely to fail. So I think when I'm evaluating a revision acetabular implant, there's a checklist that I go through in my mind. So I want to see a highly porous material that promotes ingrowth. I like to see a surface that really has a high coefficient of friction. Our idea there is to minimize micromotion and really help establish that press fit early on. The more robust our fixation options are that will help promote that stability and allow that long-term bony ingrowth. I really like to see intraoperative adaptability, which helps me really kind of make complex bone loss patterns, which are really unique. I can really address those with a system that gives me more adaptability. And then I like to see flexibility on the articular side, which will allow me to accommodate different bearing options. If I want to use polyethylene, if I want to use dual mobility, if I want to use, whatever, if I need constraint, I have all of those options available to me. So that takes us into really the design features of the Redapt revision acetabular system. So I think it's important to understand that this system was built from the ground up on the Conceloc advanced porous titanium, and we'll spend some time talking a lot about that material, but that's really the backbone of this system. So it's a Ti-6 titanium alloy that's created from 3D printing or additive manufacturing. It has an overall porosity of about 67%, but because it's created through additive manufacturing, they can control the porosity at different areas in the cup. So near the surface that's opposed to bone, that porosity goes up to about 80%. And if you look at the pore size, the average pore size throughout the material is in the 200 to 350 micron range, but closer to the surface again, because that can be controlled with additive manufacturing. The pore size is a little bigger in that optimum, about 500 microns to right around 900 microns. So really an ideal pore size for bony ingrowth. The other thing I like about this material a lot is the modulus of elasticity. When you look at this, the modulus of elasticity, it's really very similar to cancellous bone. So you can see on the graph, Conceloc has a modulus of elasticity of about 4.5 gigapascals, cancellous bones in the 3 gigapascal range, and obviously cortical bone is much higher, almost 17 gigapascals. So this really closely mimics that. And I think the real benefit is in these patients who already have diseased host bone. They really have pathologic bone. This helps to minimize that stress shielding. If you have a really, really stiff construct, that can lead to stress shielding and greater bone loss in an already challenging situation over time. The other benefit of this material is that, as I mentioned, this high friction surface, they were able to place these topographically mapped bumps, which really help to aid in that initial stability with your press fit. And if you look at the coefficient of friction of this material, it's quite high, greater than 0.95. Stick tight is very similar. and slightly higher even than trabecular metal or porous tantalum. Although I will point out that those two testing methodologies were slightly different, but that was the reported coefficient of friction for porous tantalum. The REDAPT revision system makes use of variable angle locking screws. So the real benefit here is this allows greater freedom for placing your screws when you have these severe bone loss situations, like you would have in a cup without locking screws. But of course, because of the locking technology, we can have that large cone of freedom up to 12 degrees, 6 degrees in any direction, and still have a locking screw. Now, the real beauty of the locking screws is that it helps enhance that initial stability. So if you look at the overall stiffness of a construct using locking screws or non-locking screws, the locking screws increase the construct rigidity by 7-fold compared to non-locking screws. So quite impressive ability to increase the stiffness overall of that construct. The REDAPT revision system also has a really optimized screw hole pattern. So for the smaller cups, the 48 through 58, you get a 9-hole pattern. And then once you get to the 60 and up, so up to 80 millimeters, you're given a 12-hole pattern. And a unique feature about the revision of the REDAPT revision system is the pubic and the ischial screws. So in both cup systems, you have 2 screw holes near the ischium and near the pubis. And the benefit of this is, these are really well placed. They're very peripheral. So you really have good access to the ischium and to the pubis. And then you don't have to drill through the hole and create metal debris and hope that you're in the right spot with your drill holes. So I have found these particular screw holes to be quite valuable and really positioned well. So the REDAPT system also has a modular cup. So this cup uses the R3 modular locking mechanism, which has been around for a decade or longer. We use the R3 instruments to insert this cup. And the beauty with this cup is it's compatible with all other R3 modular trials and bearing options. So all 5 or 6, really technically 6 different polyethylene options for the R3, if you include the constrained option and the OR30 dual mobility bearing, are all available with this revision modular shell. And then the fully porous cup is also, I made a mistake there. It does not use the R3 modular locking mechanism, but it does use the R3 instruments. Our option here is there are a series of cemented liners, which really, I think, provide you a lot of flexibility if your acetabular orientation is suboptimal, which you will frequently find in these scenarios with severe bone loss. So you've got a bunch of different polyethylene configurations. You can also cement a polar cup into this, and then you have a dual mobility option as well. So I've found this cemented liner to be really appealing in these situations. And then the real power, I think, in this system is the ability now to have augments that go along with this system. And these augments are, again, made from the Conceloc porous titanium. They all have the variable angle locking screws. The 2 main augments are either a staple or a slice, and they all come equipped with these cement ports. And the cement ports are really nice because you can place the augment and the cup where they need to be. You can get screw fixation, and then you can cement those together and unitize the construct, as opposed to other systems where you have to place cement and then really try to get everything into position very quickly before the cement polymerizes. This one allows you plenty of working time. You get everything in position. You can fix everything with screws and then lock it with cement through those cement ports. A really, really, I think, great design feature of this system. This slide was really just to demonstrate the vast array of augments and sizes. The augments are designed to fit. Each augment fits basically 3 shells, except for the very largest augment, and that one is compatible with the 5 largest shell sizes. On the staple, you can go from 8 millimeters to 18 millimeters, and for the slice augment, you can go from 12 to 24 millimeters. And then the last aspect to this augment system is the blade augment, and I think this is just a really well-designed instrument here. It's a buttress style augment, so it's really valuable for those massive uncontained superior defects or large anterior posterior columnar defects. Because it's a 2-piece design, it really allows unlimited customization. The idea here is that the lower part is fixed first, and then you can attach the upper blade to the ilium. And because they're not mechanically attached, you really can get great customization. You get a good flush fit. And then once you've got everything locked into position with screws, you unitize the two with cement, and it really creates an incredibly robust construct. The other thing, I think one of the design features that's really well thought out about this augment is the outer surface has been polished really to help prevent soft tissue abrasion, where other augments oftentimes will have that porous surface throughout, even on that exposed soft tissue surface. So this has been a really, really well thought out and well designed augment system. Okay, so we'll go through a couple of cases, I think, just to help demonstrate some of the powerful features of this revision system. So my first case is a 39-year-old male. He's 18 years status post total hip arthroplasty. He had a total hip while he was in college. He was 21 years old. He had AVN, which was likely secondary to a slip capital femoral epiphysis. He's had painful ambulation for several months. Really what's most disturbing to this gentleman is his leg length discrepancy. He felt like he grew quite a bit after his hip replacement and has developed about 1.5 inch leg length discrepancy. And more than anything, he's interested in having his leg length discrepancy addressed. So here is an AP hip and a lateral of his hip. You can see he has a cemented femoral component and a cementless acetabular component. On the AP pelvis, you can see he has massive periacetabular osteolysis, severe osteolysis down almost all the way to his pubic symphysis. If we go back to that lateral view, you can see he does have an intact posterior column. So I didn't feel like we were dealing with a pelvic discontinuity. So with this gentleman, I knew that we were going to have a significant challenge on our hands. We wanted to lengthen him some. And so my plan for surgery was a tap out, tap in on his femoral side, and then acetabular reconstruction utilizing the REDAP system. Now, I was prepared for a lot of different scenarios. I was certainly worried that we may end up with a discontinuity with this gentleman. And so I'll show what we were able to accomplish with the REDAP system. So I was able to use a 70 millimeter fully porous shell. I used a 68 by 12 millimeter slice augment. You can see posterior superior. And then I used a 40 millimeter neutral liner. And I was able to get him quite a bit of length back on both the femoral and on the acetabular side by restoring his center of rotation back to its anatomic position. I used about 120 cc's of bone graft in his pubis and ischium. And he's done quite well. He's an engineer for a large construction firm here in the Omaha metro area, and is back to doing everything that you would expect out of a healthy 39-year-old male. And so I think, the power here with this system, I was able to bring his center of rotation back down with that augment and got excellent press fit with this cup. able to put several locking screws, one down, you can see that nice locking screw down into his ischium, a long locking screw up into his iliac bone. And so this is, I think, proven to be a really good reconstruction for this gentleman. Again, radiographs just demonstrating those screw positions. I think if you look on the lateral radiograph here, it's really telling. You can see the position of that screw in his ischium. That's a really valuable screw. Having the augment superiorly to buttress that cup from cantilever forces, and then having that locking screw in the ischium, I think really makes a huge difference in these cases. And then my second case that I'd like to share is a 59-year-old gentleman with a long history of right hip pain. Unfortunately, he also has a history of alcohol, cocaine, and methamphetamine abuse. When I saw him, I was very concerned about a history of infection. And when you see his x-ray, you'll understand why. I did send him for an aspiration twice, and his aspirate was negative on both times. And so here you can see right hip with severe acetabular bone loss. This is a challenging situation regardless. The posterior column is intact, but given the loss superiorly, you would think that certainly a superior augment is going to be required. So I'll show you our reconstruction. So again, and you can see a 74 millimeter fully porous cup. And on top of a 74 millimeter cup, we used a 24 millimeter augment. For this gentleman, I used the cemented polar cup. We placed a 55 millimeter cemented polar cup. And I think overall, if you look at his length and offset reconstruction, we've done a really good job. And he's done quite well, and it's about actually a little over a year and a half out from this reconstruction and doing very well. And so I think that ends my presentation, and I'll now turn it back over to you, Rand.
Okay. Thank you, everyone. I have the pleasure of being the third one after Curtis and David. I'll be talking now on how to use dual mobility, talk a bit about dual mobility and how I use it in my practice. My disclosures are here. The only relevant one is my relationship with our sponsor tonight. So dual mobility. We all know the current indications for dual mobility. And if you look at the data that we have from the AJRR, you can see there's an increasing use in dual mobility, especially in revisions. It's becoming a dominant player in revision cases, as well as in instability and complex cases. What do we call high-risk patients? So for me in my practice, patients that I start thinking about dual mobility is patients with femoral neck fractures, conversion, total hips, patients with cognitive impairment, compromised abductors, especially patients with hip spine, lumbar fusion, and fusions down to the pelvis. And on the same token, patients with stiff spines and non-spine fusions from surgery, but more of a natural arthritis development. If you look at some of the work that's been done in the last few years, you can see how dual mobility has been showing better outcomes from large femoral heads, even though now we have a big randomized study that's been run from Rush, which we are taking part in, that we're trying to compare dual mobility in large heads as well, in revisions and complex cases. And part of the reason for such a randomized study was from the data that we have that's pointing towards advancements and advantages in using dual mobility in these complex cases. So when we think dual mobility, what are the things that are the different that make us contemplate to use a big head versus dual mobility? So what can be the downsides of dual mobility? You can have liner corrosion, which we have more and more data coming out showing that there's shredding, corrosion, and damage in retrieved dual mobility cases. We know that there's metal ions that's starting to come up, and that also brings up the question about use of dual mobility in younger populations. We know there's a risk of intraprosthetic disassociation or dislocation. I personally have to admit that I haven't seen intraprosthetic dislocation in one of the modern designs happening in situ. I do see it very commonly if the hip did dislocate and a reduction attempt in the emergency room is tried. I think there's a very high likelihood of intraprosthetic disassociation then. What about liner malseating? There's different systems out there, and some of them are more prone for liner malseating, which can lead to liner corrosion, metal wear, and even a disassociation, a dislocation of that liner from the cup itself. And another thing that we've been seeing a lot, and you can see here both on the X-ray and on this in vivo X-ray and in vivo stem, is the notching on the stem. So what is the notching? The notching is actually, from some of the designs, as you can see in the picture above, there's an elevated rim for the dual mobility liner itself, and that notches on the stem. And this usually happens on the extension. So that happens when it notches posteriorly, and it slowly eats into the neck. And we've seen some cases that become very drastic and actually need extraction of the stem. So when we think about corrosion and release of metal ions with cobalt chrome liners, of course, it's the cobalt chrome liner that sits on that titanium shell that causes this corrosion and causes the metal ion release. And as I said, there's more and more evidence showing that this is not something that we can forget. It's something that we have to take into account, and we have to see how this goes with further and more longer term follow-up. And you can see here on these images, you can see the areas of corrosion. You can see the black and the material that happens there. And when we start thinking about young patients, and is it viable on every young patient? Because they're usually high active, they do yoga, they do exercises. We do see these cobalt levels that increase over time. So the fretting and the corrosion is something we need to think about. It's still early. These are still smaller numbers. These are still things we're not sure if they're clinically relevant or not, but they are statistically evident. We do see them, and we do see them in larger and increasing amounts. So let's talk a little bit about the OR3O, the dual mobility. What's the differences and what are the advantages of it? And we have the advantages of stability. This is every dual mobility, but here's as well, we'll talk about the self-centering design, increased range of motion, and increased jump distance that are one of the main advantages of stability for dual mobility. The safety, it minimizes corrosion. We don't have cobalt chrome in the system. This is works on Verilast, which is the oxinium and the XLP liner, lower rate. And the oxinium is an advanced oxinium that's much thicker and has much more characteristics for long-term endurance. Simplicity, in order to align the liner in well, so we don't have malseating, we have this large alignment peg. There's an 18-degree taper that helps seat this the liner and have better contact. There's less micro motion. It's very easy to remove the liner, which is similar to the whole system of the R3 and the Redapt cup, where it's very easy to remove and insert the liners. And as well, cup selection, you can use any cup that's available in the system. So if you look quickly about the eccentricity and the self-aligning poly, you can see here in the image, you can see as the hip rotates, instead of the larger head getting stuck and sitting, and then you can have impingement between that larger head and the neck, and only then the larger head goes into motion. You have here the self-aligning torque that pushes the larger head into place, into a more an ideal position. Doesn't matter where the stem and the vector of force goes through that neck and head into that acetabulum. Now let's start talking, how do we use these dual mobilities? How do I use them? So my original use of dual mobility, before it became much more common in more primary and less complex cases, was in revision cases. So I use in very complex cases, like Curtis showed, a fully porous cup. And like he showed in his second case there, I like to cement the dual mobility into that, because it allows me both to put the first cup, the fully porous cup, in a good position for bony ingrowth and stability of the construct, and then allows me to cement the dual mobility secondary cup liner into a better position for instability, for hip stability. So I can add a little bit more abduction, I can add a little bit more aneversion in relation to the first preliminary fully porous cup. So we published a couple of papers on this already, showing the reconstruction. The first paper was a more preliminary. This was, I think, before the time of the Redapt was even out in the market, and I was cementing the polar and any available fully porous cup that I had to use or was already in there, and we did not remove. And we showed there's very low dislocation rates, and we haven't had one case that the polar cup had dislodged from the fully porous cup we cemented into. And this was with 36 cases. This was a multi-center together with Rush in Chicago. We combined cases here and we showed the good outcome. We didn't see any loosening or fixation failures in this construct. And you can see the construct there on the right. Then I moved forward, and after the redapt cup fully porous came up, I have used it in all my cases of acetabular reconstruction. So we looked at the specific combination of the polar cup into the redapt cup, and we had 38 cases with good follow-up. And you can see here in the images, and I'll show you a few pictures, what are the steps that we do it in. And again, we showed 0 failures of the construct. I think we had 1 dislocation that happened immediately after surgery in one of the centers, and the hip was reduced, closed, and the patient did well. So this is how the construct looks and how it goes step by step. I'll go in the picture and show this is a large acetabular defect. This is the cup that I removed. Here you can see the redapt fully porous cup placed into that acetabulum for the reconstruction. You can see even from the picture, it's a little bit more vertical than you would like your cup. It's not anteverted enough. Here you can see I'm planning where to cement the polar cup, how much more abduction I want, how much more version. I'm analyzing, seeing if I'm happy with that. And here you can see I cemented the polar cup in. You can see the polar cup with a 20-degree lip that it has, pointing in the proper direction. You can see here the trial reduction with the head. I see that I like it. And then I finalize it. Let's talk about the polar cup in the two, not the polar cup, sorry, the OR30 in the 2 cups available. You can see the redapt in the R3, so you can use it from a primary cup to a more complex revision cup. The redapt model allows the dual mobility to lock in. You can see on the image on the left on the ease of insertion, you can see that large alignment peg. I personally think it's impossible to put this liner in a bad position with that peg and the taper, and the ease to take it out is very similar to taking out a regular XLP polyethylene liner. Let me show you a few cases, and I'll go from very simple to show you the use of dual mobility quickly. I won't spend a lot of time. Then we'll show some more complex cases. And after that, we'll have a whole case discussion with David and Curtis and talk about a little bit more complex cases. So a primary case that I would use it as an elderly patient with very stiff spine, and I just want a higher level of security. What I do recommend when using dual mobility is to be very familiar with the different sizes. Every dual mobility system, if you're putting a 50 cup, the head size that you get will be a 38 or a 36. And some of the systems, the heads that you can put in there are 32 and 36 anyway. So dual mobilities have less of advantage, I think, in smaller acetabulum, especially in those areas of around 48 to 52. But as you grow bigger and as patients that are bigger, you really get these large heads that give you a huge advantage in the jump distance. It's one of the big advantages of the dual mobility. And here you can see I put an R3 cup. I cemented a stem. This is a very elderly patient. I cement a lot of my older patients. And you can see the dual mobility here that I used. I put 2 screws in all of my R3 cups and all of my primary, so nothing unusual there for me. Another type of complex case that I'll automatically think I want to use a dual mobility, as we said, the hip spine cases, patients with no spine mobility. This patient has a cervical to pelvis fusion. I do these standing and sitting lateral and AP x-rays. I can see that there's actually no motion. There's less than 3 degrees of motion when the patient sits. And probably that's even just because she's moving other parts of her body and not through those screws, of course. You can see the destruction on the right side, a little bit more complex. That's acetabulum reconstruction. She's going to miss some of her dome on that side. I do my planning. I'm planning a primary stem. I'm planning a redapt modular cup as an option if I don't think the R3 is sufficient. And you can see here the multiple screws that I used, dual mobility head to get more support because I didn't have a lot of support around that cup. There was enough exposed cup that I wanted more secure screws. So let's go to a little bit of a simple revisions. This is a 77-year-old female with a history of instability on the right side, history of right toe hip and left toe hip. Both of them have dislocated a few times, and her left toe hip is becoming problematic. And you can see these dislocations. You can see the cup is very anteverted and vertical, and the patient had a few anterior dislocations in the last few months. And you can see an image here of her anterior dislocation on that side. Then she came in with another dislocation. And now we have to do a revision. So I plan to revise the cup. This is a REDAP modular cup with a locking screw mechanism. And you can see the dual mobility, that large head that's placed in there. I always use a navigation system when I do these cup revisions. I first tag the original cup. Here it was 47 of inclination and 38 of anaversion. I before the surgery, I already planned how much I wanted to deviate from what the original cup was in there. So I plan to bring the inclination closer to 40, and I plan to bring the anaversion more towards 25, 23, in order to decrease the risk of anterior dislocation, but not all of a sudden give her posterior instability. So with navigation, doing that change is extremely easy. I think that trying to change cup position without navigation, I find it challenging, because after you take out the old cup and some bone gets destroyed and you clean everything up, by then you forget how the previous cup was in relation to the anatomy. And a lot of times it's hard even to see the anatomy with the original cup inside, because you can't always see the dome of the acetabulum. So I really like using navigation in these cases. So another case, 58-year-old female complaining of right hip pain. Right toe hip was done about 5 years ago. Patient is obese. Her BMI is 53. Unfortunately, I can't tell the patient that we cannot operate on her due to her BMI, because you can all see what happened. She had a polyethylene that fractured or dislodged. She's currently articulating with her head on her cup. This system has a few case reports and case series out on problems with the poly dislodging. So it was something that we expected. If these polys are not placed in well, they tend to have some of these complications. But also this patient is a BMI that's above normal weight. You can see here the metallosis that you can see inside that wound, the black tar looking color. You can see here in that acetabulum, you can see where that ceramic head was rubbing in and taking out titanium mass. You can see the fractured poly and the ceramic head there. So I'm planning to put a REDAPT modular and put a dual mobility. This patient is a high risk for dislocation in my mind. It's heavy BMI, previous fracture, and a revision, of course. So the combination is a high dislocation. So you can put here these long screws I like to place up, and screws into the ischium, and everywhere I can. I basically drill almost every hole in the cup and check where I can get good fixation. I always get the question, how do I decide if I'm going to use the modular REDAPT cup or I'm going to use the fully porous REDAPT cup? So in my mind, they have the same screw fixation. They have the same ingrowth fixation. So from a fixation standpoint, unless I really think I need to do something off-label and drill new holes through the REDAPT porous, which I have to say I do not do that often, because the screw holes are usually where I want them. If you just pay attention to put the screw holes in the ischium position where you want to try and find ischial screws, usually I don't have to try and drill new holes, which is off-label use on the REDAPT porous cup. So to answer the question I brought up, if I think I can put the cup in the good position for hip stability, that means I can put it in the proper inclination and aversion and still have great fixation onto the bone, I'll use the REDAPT modular. If I think that I cannot place this cup in the best position for stability and get good bony fixation, and I need to place it in more vertical position and less anaverted, then I'll go for the REDAPT fully porous. That's kind of the way how I decide between the two, because you can use augments, as Curtis showed, with the REDAPT modular. You can use them with the REDAPT fully porous. So there's no real difference in the reconstruction. It's just, can I put this cup where I want it, or I will put it in a different position. I'll cement into it the polar cup to get the good hip stability position. I'll show one more case, and then I think we'll join together as a group and go over some cases together. So this is a 53 female, previous history of previous toe hip, referred long-standing draining sinus infection, just to show an infection case. So this patient has an infection on the left side. You can already see some loosening around the stem, loosening around the cup. So I'm planning a two-stage revision for this patient. So I put a functional spacer, articulating spacer. Patient had a fall and now had a fracture. So we kept her off her leg a little bit to complete the antibiotic treatment, and then came back to the second stage when all of her markers were better. And here I did a reconstruction. My go-to revision stem is the REDAPT monolithic monoblock stem. I have good experience doing 3Bs and even some type 4 femurs with it. cables to fix the fracture. And here you can see the REDAP modular with dual mobility for better stability for this patient. The patient had a fracture, patient had a revision, an infection, and I thought a dual mobility will be better for her stability and for her risk, and the patient did well. I think I'll keep this case for our next group discussion, and I'll see you back in a second here. Thank you, everyone. Okay, thank you, everyone. So I think now we got to the point where we're going to do our case presentation and discussion with Curtis and David. We have 4 interesting cases for you guys to present, and we'll discuss among ourselves what our opinions are, what our thoughts are. So I'll let David start with the first case. David, you got it.
Okay, so this is an interesting case that I think is very challenging in most centers. This is a 96-year-old female, absolutely delightful lady, lives alone, drives, does her own grocery shopping, is active, golfs, who had a ground level fall and presents to the emergency room with this right hip injury. I'll just point out the pertinent aspects on this x-ray, just in case some folks aren't used to looking at acetabular fractures. You can see that she has protrusion of the femoral head. This is the ilioischial line representing the posterior column. You can see the iliopectineal line representing the anterior column. The head is through, and we have impaction of the dome, centralized or medialized quadrilateral plate.
So David, when I'm looking at this, is it right to assume that a lot of these fractures of the older patients, when you have that protrusion, that the posterior column usually is intact, and usually they go through that plate and anterior column, or do they usually lose their posterior column?
So the typical pattern in the elderly low energy acetabular fracture is something called an anterior column posterior hemitransverse. So both columns tend to be involved to some extent or another. What's interesting is depending on the degree of column displacement, the head will usually follow one of the columns. When you see the head protruding through both the anterior and posterior columns, this, to my mind, is sort of the kiss of death for this socket. It usually means that you have this areas of dome impaction is just sort of smushed through. And from a fracture surgeon's point of view, this is not something that's going to remotely do well with pure open reduction or fixation.
Okay. To take us through the more imaging before we start thinking about what we can do.
This is a CT scan. Just the reconstruction, sort of give you a better visualization or idea of what's going on here. If you look at the iliac oblique, so this is the 3D reconstruction, rotated looking iliac oblique, you can see that the anterior column fracture is incomplete and the posterior column fracture is undisplaced. Anterior column incomplete, protrused head, displaced quadrilateral plate. If we were to go through the axial scans, which I've not included here, but we do have just a coronal, you can see that the dome is impacted. So this is sort of a marginally impacted dome. It's been described as the gull sign, sort of looks like a seagull here. And it's published in a paper called The Harbinger of Failure in Attempts at Open Reduction or Fixation. So this is a fracture that if you look at from a pure, can I fix this point of view, really a very limited success rate.
Okay. Curtis, when you see a patient like this coming in and you have to treat it, what's your plan?
Yeah, so I agree with David. These are really complicated. This is a patient where, if I look at this with my trauma surgeons and with that marginal impaction, I think that's the really hard thing. You may get the column stabilized, but they ride up into that defect, and then 3 months later, their X-rays look just like this, except they have some plates and screws. And now, now they've already had a Coker-Langenbeck approach, and they're scarred up. And so I think these, I like to think about doing an acute total hip on these. It's a complicated total hip replacement. There's no doubt. But I think they do a lot better than when you try to fix them and then have to go back and do a total hip after it falls apart. So this is one where I think sometimes plating either the anterior column or the posterior column and then doing a press fit acetabular component with a whole bunch of screws, getting, fixation inferior and superior. We've got a series of these where we actually do a modified Stappa approach and plate the anterior column, and then flip the patient over and do a posterior approach and do, just a primary total hip with a highly porous metal cup and a bunch of screws. I always have a cage available for these to do a cup cage if I'm not confident that I'm going to have great stability with a cup. But I think, I would like to study this CT scan a little bit, but this would be one where I would think if you plated the anterior column, got good stability in the anterior column, then you'd be able to get a cup in there, and I think you could make your cup stable with a bunch of screws.
Yeah, I agree with you. I think from the femur side, there's not a lot to discuss, but a 96-year-old in my hands, they'll probably get a cemented femur in there, just for me to feel comfortable. But you can do other stuff as well. I agree with you on the cup side. My thoughts, and we'll hear what David did. If there is a pelvic dissociation, we have to bridge it somehow. So it's either a cup cage or a plate. And I think I'm not a trauma surgeon. David is. He feels comfortable also with the plating. But if I bring one of my trauma colleagues, you just have to remind them you're going to be putting a cup in there. So they have to bridge it, and they're happy. They don't have to try and reduce anything. They're basically just putting the pelvis together so it doesn't distract when I'm putting my cup in there. So it's not a difficult plating for them. So I think in this kind of case, I will do together with one of my trauma colleagues. They'll throw in a plate, screws far away from the acetabulum, and I'll then reconstruct the acetabulum, and I'll be cementing a femur in there. David, what did you do?
So this is a big part of my practice. I do a fair number of acetabular fractures, and a lot of elderly acetabular fractures that I'm doing fixation with total hip at the same time. And my practice really has evolved over the years. And we'll get into that more in just a second, but I just want to point out the fractures of the columns are incomplete. They're displaced, but you can see that they are incomplete. So this is something that has absolutely no medial support whatsoever. But the column fractures are the posterior column is there, it's low and it's non-displaced, and the anterior column fracture, although it's there, is incomplete. If you look at the geriatric population, this is a problem in the literature that doesn't really have a good answer just yet. There's a few issues related to these folks that are different than, say, our elective hip practice. Number one, this happens just from a ground level fall, so their degree of osteoporosis is greater than even the osteoporotic patients we're seeing in our regular elective practices. Number two, their physiologic reserve is not there. There's a reason, even though they're active and they're an active elderly person, there's a reason they're falling. And these patients have not been optimized for surgery the way our elective patients are. And so when you start contemplating going through anterior approaches, anterior interpelvic approaches and plating, and then doing other exposures, that's a lot of potentially a lot of fluid shifts and bleeding for these elderly patients. So what I used to do for this type of pattern, I would usually go posterior, plate my posterior column, percutaneously fix the anterior column, and then do a cup cage reconstruction, because this wants to medialize. That's how this is going to fail. And if you look at the literature on total hip for acetabular fractures, that's how they fail. The cup migrates and medializes. This patient was 96, incomplete fractures, and I did this, it's probably about a year and a half, 2 years ago, and I had just sort of been getting going on the Redapt revision cup with its locking screws. And given that she was 96, I liked it to do something maybe just a little bit edgy. And here it is. This case was done from an anterior approach. You can see I did not fix the columns. This is her femoral head used as medial graft. And this is a redapt cup with circumferential locking, primary stem. Surgical time was under an hour, minimal fluid loss. And this
that looks great. And I think I agree with you when we don't have a complete fraction, we don't think we have a dissociation, that we can put the fully porous cup or the regular redapt cup with good screws on both sides. And she's walking really nice at 4 weeks. So I see you also didn't restrict her weight bearing after you completed the reconstruction, right?
So she had unrestricted weight bearing right from the get-go. That is edgy, but that is sort of where my practice is just evolving with these cases. A more complex fracture is clearly going to get plates and screws stabilizing the fracture, although usually more limited approaches. I'm sort of doing a lot of lateral windows, fixing the anterior column, percutaneously stabilizing the posterior column, and again doing an anterior total hip in these patients, trying to minimize the amount of dissection and blood loss.
Yeah, I agree that probably trying to do it all in one incision. So if you do all from the back, then do the back. If you're doing it from the front, then try and do it from the front. I'll probably be more conservative and tell her that she has to use a walker for a while.
Yeah.
Fell once. Okay, that's a great case and a great outcome. Curtis, do you want to share us one of your cases?
Okay, this patient is an 88-year-old female. She had primary total hip at an outside hospital. Unfortunately, they had a little intraoperative difficulty. And so they called and said, can we transfer her your way? I was in the middle of clinic. We accepted her for transfer. I think we had her scheduled for the next day or maybe the day after. I show up the morning to do her surgery, and I find out she's in the ICU. She was taken urgently to the operating room overnight by the trauma surgery team. She had an acute abdomen with pneumatosis coli and had a total colectomy. And now, in addition to what you're about to see on her X-ray, she has a colostomy, a fresh colostomy, and a big midline abdominal incision. So here's her X-ray. I do apologize. I didn't get her CT scan loaded into this, but I think these. I'm seeing more and more of these, David. I'm sure you're seeing more and more of these as well. And I think in general they tend to be pretty predictable. I don't have additional imaging. You want to talk us through and what you think about this?
So, just to say, I agree that it's funny, but in the last month, I had 2 cases like this transferred to me.
Yeah.
And the one thing that I was thinking, if the surgeon's having difficulty in the operating room and this in general, and they think something went wrong, they should get an X-ray. And if they got an X-ray and they see something like this and they know they can't treat it, that this patient's getting transferred, I think it's better if they take everything out if they can, because they just put it in. It's better to put these patients on girdle stone, because I've seen a few that were almost there and the patient stepped on it and then the cup went into the pelvis. And then the surgeon knew that patient will need to have another surgery. So, I'm sometimes curious why they just don't take everything out and leave a girdle stone, and it's better than this.
I think this patient actually did have her cup put in, and they knew something wasn't right, but cup looked okay, and she got up and walked on day 0, and this is what happened.
Yeah. So so when I evaluate this X-ray, I think the first thing, as we discussed before, do we have a dissociation? It's kind of obvious here, but the main signs that you're looking for is the obturator foramens not looking equal, and it's that ischial line and the pectineal line just not connecting. So if you try and imagine those lines, that iliac wing is not in the same plane as the bottom part of the pelvis. Do you agree, David?
Absolutely agree. Yeah.
Yeah.
Sorry, how long post-op was this?
This X-ray is like, I don't know, 2 or 3 days.
Oh, okay.
Okay. So So let's I'll go first, and then David will say what he'll do. I think it won't be much different. I think the main thing here is this acute or this is subchronic? So I had a few come in 3 months later versus come in 2 or 3 days. The 2-3 days are, in my mind, easier because when this starts becoming subacute or more chronic, the main problem is dislocating. All of the scar tissue, there's no range of motion. And I had cases where I had to do an ETO and even cut the neck of the stem off just to get access to take the things out. So an acute thing, I know I'll be able to move it, but your patient already had abdominal surgery. But let's say the patient didn't have abdominal surgery. This is a case that's worth to get a CT angio if the patient is stable, in my mind, just to know, because I operate in an orthopedic specialty hospital. I don't have vascular sitting next door. So my question to them, should this patient be operated in the main hospital where I have vascular, or is it enough in the orthopedic hospital with the vascular surgeon sitting in the lounge and coming in if needed? Because I had cases where I had vascular put in a sheet and actually be ready and knowing that I may cause damage, but they already had the sheet inside of the artery and they can just put a graft if they wanted to. So I would do a CT angio in this kind of case. The chronic ones where I see the bone all around the cup, I usually don't. And then, I think everything will come out easy because it's been acute. And then for me, this is a cup and cage reconstruction. A lot of times when you try and plate these, there's actually no bone to bring together that easily. And sometimes David will comment better. I think that the plate may be in the way of where I want to put the cup. And then I'll put a plate, then I'll try and lodge a cup and it'll be hitting the plate, especially if you put the plate on the medial side to kind of bridge. What do you think, David?
Just a couple of questions. Her surgical exposure was what? This was done from an anterior approach that kind of went wrong?
Posterior
approach.
Yeah.
I think the huge distinction between a couple days post-op as opposed to a couple months or that sort of thing, and a totally different approach. It's clearly a discontinuity, but it's an acute fracture. This is not an established discontinuity with minimal healing potential and that sort of thing. So I sort of hedge my bets a little bit on exactly how my reconstruction is going to go. My favorite technique would be fracture fixation, followed by the reconstruction. You don't know how much they've reamed away until you get in there and look. And even CT, you're really not going to appreciate it because of the metal artifacts. So this is something where my goals of surgery, I'm going to attempt fracture fixation. Recognize it's not going to be anatomic. I may not get a perfect alignment of the columns, but I don't really have to. I can still expect fracture healing. It may be with callus, but this is not an established discontinuity where there's scar and it's not going to want to heal. So ideally, I'm going to get fixation of the posterior column. I'm going to bring that back in and somewhat close down the volume of that acetabular discontinuity or gap. Then I would plan and hope for a reconstruction with a redap cup, hanging screws circumferentially, maybe anterior column fixation percutaneously. But I agree with you, Rand, that the more fixation you put in to stabilize the fracture, the more likely it is to create difficulties with your cup positioning. One of the real things you don't want to do is say, hey, my trauma buddy, can you fix this fracture for me? And then come in after they put plates and screws everywhere and they've squeezed the socket down to about a 40 millimeter gap, because that's horrible. Then nothing works. But for me, this is acute fracture fixation, reconstruction with a hemispherical cup. Depending on my fracture fixation, I might use a cup cage, but I prefer not to. I'd rather go with just a hemispherical cup with fracture stabilization.
David, I have a question for you. I thought about it. I never done it yet, but let's say I want to fix it. And can I put in like a trial 56, leave it in the socket while the trauma surgeon is fixing and tell him, don't squeeze, keep this trial in there. Don't hit it with anything and don't squeeze it too much.
Yes. So I actually, another case I was going to show, one I did not too long ago, a fairly complex acetabular fracture, associated both column, sort of open at the lateral window, plate from the wing down to the socket, posterior column fixation, then I leave my anterior column gap. I'll start reaming my cup with the wire down for my anterior column fixation. Put my reamer, my final reamer in, leave that in, and then start squeezing down the anterior column, because there's nothing more frustrating than hitting that anterior column and you're not going to get your cup flush, you're not going to get nice bone contact. So I'll often do that. Now it's a little easier for me because I'm the trauma guy and the recon guy, but yes, you can do that.
Okay, great. So Curtis, what do you do?
Well, so I was going to ask David. So that was my question. If you're going to do percutaneous anterior column fixation, how do you do that without interfering with where you're going to put your cup, especially on these that are already medialized?
Right. So recognizing that there's no joint surface here, you don't need the columns perfect, right? You need them supportive.
Yeah.
The way I approach it is posterior approach. She's had a previous posterior approach.
Yep.
Fix the posterior column. That plate is a mile away from where you're going to ream. It's a posterior column plate, not a posterior wall plate.
Right.
The anterior column is now kind of lined up. So you bring your fluoro in, you use your shots, you put your K-wire down for a 7-3 cannulated screw or whatever screw you're going to use, and you have the K-wire there. I ream, I put my final reamer in, or even the cup, then I put my screw in after that to make sure. I don't care if the anterior column's a little bit off, and I don't care if my final cup is pushing on the screw, as long as the screw's not pushing my cup away from the bone.
Yeah.
So I'll accept a malreduction of the column as long as it's kind of supporting my cup.
So I'm gonna give you guys this situation now. I've got this lady who's got a fresh laparotomy, not a very good looking wound. She's in the ICU. She's had this big abdominal operation. She's got a fresh colostomy. Would you operate on her like that, or would you give her some?
So one option, if I'm really afraid that she's too infected, will be I would operate. The wound is fresh. It will be quick to open her. No, she's already open. I'll just take everything out, wash it out, and maybe leave some antibiotic cementive there if you're concerned for infection, and then come back in a few weeks and do when she's already stabilized and optimized again. That's one option. The question is if that's the best thing for her pelvis. David, what do you think?
So I operate on a lot of folks who are in the ICU, sick, banged up, X-laps, this sort of thing. I do a lot of arthroplasty on them when they have displaced femoral neck fractures or acute acetabular fractures. If she's not systemically septic, in other words, if she's had her belly fixed, she's not septic, yeah, she's got kind of surgical wounds or a colostomy that's fresh, I'll operate through that as long as she doesn't not actively infect it with febrile positive blood cultures. I think leaving this alone increases the complexity for the surgeon and probably is going to have not quite as good of an outcome for the patient. As our problems get more complex, our complication rates go up. I think doing something acutely here dramatically diminishes surgical time, surgical dissection, blood loss, a normal hip center, cup stability. So I would do this acutely unless she was systemically unwell or on pressors or some pressing medical reason not to.
Okay. Curtis?
Well, I was worried about her overall medical status, 88-year-old, not healthy female. And so I did what Ran had suggested, and I took her cup out. I took her stem out. I left her alone. I let this thing heal. And, she kept coming back wanting to hit. I was hopeful, actually, that she would just say, well, this is good enough for me. I've had enough surgery. But she is a pretty aggressive little 88-year-old lady. She's actually from your neck of the woods, David. And so she's got this girdle stone. She really wants a reimplantation. So this is my reconstruction for her. I was able to do this. She was healed. She healed her posterior column. I was able to do this with a 60 millimeter modular REDAP cup and a dual mobility. So you guys, give me your thoughts. You can critique. My cup's probably just a little bit vertical, but I think with the dual mobility, she was really stable. I was pretty pleased overall.
So I think if I decided to do a 2-stage on her like you did, my reconstruction will probably be similar. Maybe I would cement her stem just because kind of my rule of thumb in her age.
Yeah.
And maybe I would tend to use the REDAP fully porous and cement the polar cup in there if I felt my cup was a little bit I couldn't get in a good position. But overall, I think the reconstruction will look very similar. David?
Yeah, I agree. I think that looks pretty good. It probably looks different than if you had done something acutely, but that looks like a great reconstruction. I don't think it would have done anything different.
Right.
Okay.
Yeah, and so I would agree with you guys earlier. I like this case because if I had done this acutely, I would probably be leaning heavily toward a cup cage in her. Maybe get one of my trauma partners play posterior column and then try to do something similar. But yeah, it's just an interesting case, kind of the way it presented itself. So.
Okay, great. Thanks, Curtis. So now I'll show you guys a case. Okay, guys, this will be the last case. We had 2 good cases, so this will be the last one. This is one of my cases. This is a 60-year-old female who's been having about 6 months of pain and discomfort. She has a history of a toe hip on the left side this was, I think, a few years ago, so about 8 years now. These are x-rays from just after her surgery in 2008. She had a metal-on-metal reconstruction, and she was doing well. You can see her follow-up. We're jumping to 2014. She's been having some back pain and has been followed up by our spine surgeons. They get this full body x-ray 2015. So you can see this x-ray 2015 in December. In general, everything looks kind of normal. I don't see anything abnormal. And this is 6 months later. This is her acetabulum. You can see here when I get the obliques, you can see there's practically destruction of both columns almost. They're just kind of gone in 6 months. The cup has moved and flipped. You can see here how the cup flipped. This is the MRIs. You can see a little bit of a mass there growing on both sides. Okay, so before we go what I find in the operating room, let's go over here and have some thoughts. David, what's your thoughts here?
Right. What was the time frame between that normal X-ray and
6 months.
6 months?
Yeah.
I mean, so this is highly alarming. We've got catastrophic failure with fairly massive bone destruction in a 6-month period. So I'm clearly worried that this is potentially something other than just mechanical failure at the hip. So, was there a history of fracture? Maybe it all came from a fracture, but is there a history of metastatic disease? Concerned about this, or primary bone tumor that's eroding this. Clearly, it also could be sort of just catastrophic failure from metal ion disease, but that's not where I'm going to go to initially. I'm pretty worried about what I'm seeing here.
Yeah, so I was the same thing. So the first thing I did was infection workup. So ESR, CRP, and an aspiration, which were negative for infection. Then I did the MRI, not just to see what's going on, but to see if it's a tumor. And you got a chest x-ray and so forth. No tumor. I had my oncology colleague look at it. I had the best of our MSK radiologists tell me. Everybody said this does not look like a tumor. It was a pseudo tumor on the MRI. Everyone agreed on that. So I worked everything out. I thought to myself, this is so much for 6 months. So now we're back to this is a metal ion disease. And what's our reconstruction? Curtis, any thoughts?
Yeah, I mean, these are really, really challenging. If this is truly just an ALTR, an adverse local tissue reaction, you're going to see massive bony necrosis here. Just the fact that there's absent bone is, the least of your worries. I mean, she's got nothing here that's going to result in any sort of predictable healing. These are like tumor cases. I mean, this is
we're not plating this, David. We're not putting an anterior column screw in here.
We are not trying to fix this fracture. I sort of echo my experience with this is just like Curtis was saying. There is it's kind of like a biologic waste zone in there.
Yep.
The healing potential is pretty limited.
Okay,
there's so little healing potential here. The cases like this that I've seen. Actually, the worst one of these I've seen was actually a case of trunnion failure, and she just had massive periacetabular necrosis.
Yeah. So when you guys Curtis, when you open it up and you see this kind of yellow tissue, what do you think? Tumor, infection, or metallosis?
This has ALTR written all over it.
Yeah. So you can see that damage that happens there. You can see that I'm retracting on the top. You can see there's not a lot of troch left. The abductors are kind of flimsy. You can see all that tissue everywhere. And then you can see it's not really trunnionisis, even with this large head. There's a little bit of black. It's mostly the metal ion disease that caused that.
Hey, Rand, out of curiosity, do you remember did you check her serum metal ion levels, cobalt, chromium levels?
I think I did. I don't have them here, so I don't want to make up the numbers.
Okay.
So as you can see, that the stem looked fine, and the stem, just to remind you guys, this is a fully well-coated stem. So I decided I'm going to try and keep this stem and not take that thing out. And it's a good stem with a great track record. So I moved it out of the way. You can see that large defect there. So then after I cleaned everything, I decided I'm doing a cup and cage here. You can see the Redap the Redap porous cup there with screws, a little bit off-label screws placed in extra places around there. That's the cage placed on top of it. And I'll show you on the x-ray how I place it. Now I'm kind of planning how to put the polar cup in position, how I'm going to cement it into that cup cage construct. Here you can see the construct cemented, the large dual mobility head before we start closing. And here's the x-ray. So this is a large cup. The cup and cage is on top of it. You know, maybe I should have
what size, do you remember what size cup you got to there? That's a huge defect.
I think the cup was a 70 or something like that. It's a big cup. And I think I probably should have used a longer flange. There's on this one to get some more screws up the ischium. This was my only thing, because after you bend that flange over the cup, because it's such a huge defect, not a lot of flange left to climb on top of the ilium. I've done one recently and I used a longer flange and I was much more satisfied. But you can see those long screws going into the ilium towards the SI joint and screws into the ischium. On these cases as well, when I do the cup cage, I tend not to try and put the flange, dig it into the ischium. I actually clear the ischium and I put it on top of the ischium and I drill a hole through the cage on the side table. And then I put a screw through the flange into the ischium on the bottom. Because a lot of times when you put the cup, it actually blocks that original place where when you just put cages to go into the ischium. And I don't like putting them into the obturator foramen because it's actually not grabbing much. So I like that screw on top of the ischium. I actually saw her now for 3-year follow-up, and my sign that everything's okay, that she is pain-free and none of the screws broke. That means that she's doing fine and it grew in. So Curtis, any comments about the reconstruction?
You know, I love it. I think your reconstruction looks fantastic. You know, unfortunately, I've got some experience with a few of these as well. I think, you know, that cemented polar cup, because, you know, the point you make, it's really hard to get a cup in a really ideal position in this situation. You know, and really, I mean, when you have to use that cage, oftentimes that cage precludes you from putting the cup in an ideal position. So being able to cement that polar cup inside that cage, you know, just does so much for your overall joint stability. I think, yeah, I mean, I love your technique here. I think this looks great.
David, any comments?
Yeah, I think this. I'm happy to hear she's 3 years out, because I would have been nervous doing this. I think the only thing it looks great. I think when I'm doing these cup cages, I'll intentionally put my cup more vertical, just because of the issue you mentioned about getting that flange over, and I know I'm cementing something into it. So I typically put my cup a little bit more vertical, just for the ease of getting that in, knowing that I'm not driving my final position of my bearing surface.
Yeah, I agree. That's a great point, because you have to be able to put that cage. So before you buy the cup position, you really want to see if that cage can fit. You can put it on the ischium, you can put it on the ilium, because you may put the cup in a position that you can't put the cage in. If you try and put the cup in 40 degrees of abduction and 20 degrees of aversion, you cannot put the cage on. The cup really has to be in the original position of that acetabulum. That means a 55 degrees and like a neutral to 10 degrees aversion. Because if just think about how you put a cage without a cup, you put it on a native acetabulum. That's how the cages are designed to fit. So you really want to put that first cup in the native acetabular position, knowing that you'll cement into it something in a better position. I think that's all great points. So I think we had great cases. We had an acute fracture. We had a total hip that fractured and we fixed, and we had a cup cage now. I think it doesn't get more complex than these cases, and kind of touched on all the different techniques. I want to thank David and Curtis for joining for this session. This was a great session. I personally learned stuff that I'll take into my next complex cases. Thank you guys, and thank you everyone, and enjoy the rest of ACAS. Have a great evening.